This is a book report on values, ethics, and healthcare by Peter Duncan. It was published in 2010 in England. A quick overview, we'll discuss a couple of claims that Duncan makes early on in his book. We'll go over values, health, and healthcare, deontology versus consequentialism versus the four principles, individual and public welfare considerations, and frameworks for further thinking. So, to start off with his claims, Duncan states that healthcare professionals should be fundamentally concerned with values and ethics in their settings. And without having this concern for values and ethics, that provider can't be engaged in healthcare whatsoever, to at least to the full extent. Um, so the initial question usually is, why does it matter? And then how does this apply to me? So as we all know, our self is definitely not the best standard to hold our morals and ethics and values according to a broader sense, especially something that as complicated as the medical field. And healthcare professionals have a responsibility due to their education and training. They're the ones that know about the intricate workings of the body and should educate their patients. And also, they should be able to help influence legislature and things like that. So values, health, and healthcare. There are subjective, instrumental, and intrinsic values. Subjective values are ones that are pertinent to particular to each person, rather, likes and dislikes. Instrumental values are things that we find useful. So I value my car because I can drive it back and forth to work. And then intrinsic values are most associated with babes that we've learned about before from Clausen. Their values, assumptions, beliefs, and expectations about how the world is and how it should be, and everybody's are different and come from different sources. Also, the idea of health itself is a value. Anybody who's ever been ill has been very thankful, of their health after they've become healthy again. So we need to think about health itself as a value, and healthcare professionals learn what to do and how to do it. So again, that kind of gives them a little bit more, or much more rather, obligation, to help others in their field and patients in their field. And healthcare professionals learn what to believe and what to value, not necessarily through explicit, curriculum when they're learning their trade, but through hidden curriculum that Duncan discusses, which I took to mean the culture basically of that particular healthcare field. This is how we do things here, or these are things to do and not to do that you won't find written down. It's kind of unspoken. So deontology versus consequentialism. Deontology is a theory about our ethical behavior that states our actions should be and are guided by duty and obligation. Consequentialism states that our actions are guided by the potential consequences or outcomes of those actions. But both theories are incomplete. With deontology, it's really hard to apply that generally or universally. So, we have to think about what exactly are our obligations and to whom are we obligated. So, a good example of this is I'm CPR certified. So, if I were walking, down the street with a friend of mine who had zero health care background, and we see a person struggling to breathe and possibly having an obstructed airway, certainly I'm, more obligated to help that person than my friend who has zero experience in healthcare. So that's kind of the major issue with it. In consequentialism, um, the big problem with that is that we really never truly know the extent of our actions. And probably important to note that the largest or the most, I guess, well-known theory about consequentialism is utilitarianism, achieving the greatest amount of good for the greatest amount of people. But again, that's really difficult when we don't know the full extent of any of our actions, really. So that brings us into the four principles, which is certainly the most current theory as far as ethics and values in relation to healthcare. So I learned these same ones back when I was in hygiene school. They were actually um, first discussed by two U.S. Bioethicists, if you will. So those are autonomy, which is essentially self-governing. So that can be taken in the individual sense. Patients have autonomy, and in a larger sense that not a lot of things regulate the medical industry possibly like they should, other than internally. We kind of regulate ourselves. Beneficence kind of goes hand in hand with non-maleficence. One is doing good, and the other one is making sure you do no harm. And then, of course, justice. Um, we think of that as right and wrong and correction. So it's important to note a couple things that Duncan describes us as moral strangers. So with the diversity among us, and the diversity is constantly growing, um, our version of autonomy is now considered informed consent. So patients have the right to do what they want to do, and sometimes what we want to do crosses, individual or cultural, values. So just making sure that they're informed that if they do or don't do something, then the complications that we know that can arise because of our medical background. And it's important to note that justice encompasses distributive, natural, and legal rights. So distributive ones are ones kind of more, usually from more of a public health standpoint, allocating resources, things like that. Natural rights are moral and kind of natural human rights, if you will. And then, of course, legal rights are governed more by government systems. So the next thing to talk about are individual and public welfare considerations. So when we're talking about values and ethics in healthcare, if we've put autonomy at the forefront, we kind of have to start picking that apart into what extent do we honor autonomy. So, we can easily think about, kids, yes, they are people, but until they reach a certain age, it's well, known that they can't make decisions for themselves. So that might be easy for us to think about in that regard, but there's, quite an extension of that when we think about, the elderly patient with dementia who, really should and needs to be put into some kind of assisted living or nursing home, but she refuses to leave, her house. So, when can we tell that she's lucid versus having, an episode of dementia? And another consideration is autonomy denied if treatment is denied. So, an example of that would be, a patient with congestive heart failure that is morbidly obese and smokes a pack of cigarettes a day. And, he wants to seek treatment in the surgical form, but doesn't want to correct his lifestyle. And if something like Medicare or another, welfare system was going to be responsible for paying, does that patient get denied treatment when there's a limited number of people who can, who will be able to have that treatment paid for through this entity, or does the person who takes care of himself and just, has congestive heart failure for other reasons than his lifestyle, would that person, get preferential treatment over the person who's, autonomously deciding to not value his health. So of course, we would all expect that the patient um, who is taking care of himself and making sure his lifestyle is correct would get the surgery over the negligent patient. But some people could argue that he has the right to treatment because he has the autonomy to disrespect his body, but also the autonomy and the right and justice and all that to have treatment provided to him and for him. But we might change our view if we kind of widen the scope and look at it from that public standpoint of, well, if only X amount of people can have the surgery, who are going to allow to have that surgery to be covered as a covered benefit, the person who's not taking care of themselves or the person who is. And then Duncan also gives us some frameworks for further thinking. So he talked a lot about the actual practices day in and day out of medical ethics, but he does note, we should be aware of the ethical considerations of medical research. So, how studies are conducted, and when they're put into different phases, and even when they're in their final phases, if they're not deemed safe or acceptable yet, can they be used on patients who have no, other option if they give informed consent. But then, we have to revisit that idea of informed consent. Are they truly ever informed? And can they certainly consent to something that they don't know the entire scope of, like a healthcare professional does? Another consideration are if you are a healthcare professional, what are your values and why? And do our values and ethics shape our society? Which I think we can all agree they certainly have, but now our values and ethics changing because of our current societal climate. And then I think this last question that he raises is really important. How should we prepare for extreme ethical dilemmas? Just like with anything else, preparation is key. So how do we start to look at situations so that we can be ready if we're ever put in those situations? Quick critique, there's definitely a lack of Christian and theological foundation mentioned by Duncan in his book. We learned from Van Til that Christian morals and ethics guide, other ones. So a lot of the, early philosophers definitely were using theology, especially deontologists. We mentioned earlier, obligation and duty. They were saying we're obligated to God to perform this way, and also there was a lost opportunity in describing motivation. When people ask why do we do this, certainly believers, there's that inner Holy Spirit, and things he could have cited scripture like do unto others that we've all heard before. But in support of Duncan, he clearly and very thoroughly made cases for his claims, several case studies throughout the book that covered a wide range of potential problems that you can encounter. And he gave us a lot of thought-provoking dilemmas and encouraged further thinking. So overall, he definitely accomplished what he set out to do. And this is just a quick reference sheet. Thank you.